Good morning, everyone. Welcome to another episode of Sri Weekly Webinar Series. Today, we have a very interesting topic, how to manage hypertension in chronic kidney disease. Before we move on to the lecture, let's go to see some housekeeping rules. The webinar link will be open for you to join in from 9 a.m. to 9:45 a.m. No late attendees will be permitted. Each attendee should have been attended till the end of the webinar to obtain the CPD certificates and the CPD point. Please keep your microphones and your cameras off during the lecture. If you have any questions, you can type it in the chat box, or else you can ask the question directly at the end of the webinar. At the end, you will instantly receive the certificate once you fill the Google form. Kindly use the format followed by the surname. Don't use any prefixes. Now, let's move on to talk about today's lecture. We have Dr. Nadeesha Nishanthi, consultant nephrologist, teaching hospital, Anuradhapura. She obtained her MD in medicine in 2015, and she completed her foreign training in UK. And she was board certified as a consultant nephrologist in 2019, and currently working as a consultant nephrologist at teaching hospital, Anuradhapura. She has 3 international publications to her name, and she was awarded the Most Innovative Outstation Physician Award in 2022 for expansion of chronic kidney disease services in the northern and north central provinces in Sri Lanka. So we are today very esteemed to have you present us with the topic today, madam, an update on the management of hypertension in chronic kidney disease. Over to you to continue your lecture. Thank you.
Thank you, Malinder, for that kind introduction. Today, my topic is update on management of hypertension in chronic kidney disease. So I will first move to my case scenario number 1. 28-year-old farmer from Padaviya presented with headache and his blood pressure was 170 over 110 millimeter mercury on admission. His 24-hour ward blood pressure recording was persistently high. Blood pressure was 160 over 100. He denied any intermittent episodes of, hello? You can't see the slides, right?
Madam, I think you have not shared the screen with the audience.
I will do that. Now done?
Now can see, madam.
Okay. So my patient now can see?
Yes, madam, can see. Can see, madam, yes.
He presented with blood pressure of 170 over 100, and he denied any intermittent episodes of headache, palpitations, or recurrent episodes of shortness of breath. On examination, however, he is not having any features of Cushing's, acromegaly, and no renal bruise, no renal radioradial or radiofemoral delays. And the peripheral pulses are equally palpable. And the cranial nerves are intact, and fundoscopy, there is no evidence of hypertensive retinopathy. So what are the key steps in physical examination? We should check the BMI and whether he is having any hypertension, end organ damage like CVAs, heart failure, end-stage renal failure, hypertensive retinopathy, like that. And we need to know whether he is having any underlying cause for the hypertension. We have to do that if the patient is less than 40 years old with grade 2 or more hypertension. We need to exclude other secondary causes of hypertension, either polycystic kidney disease, coarctation of the aorta, renal artery stenosis, Cushing's, acromegaly, hypothyroidism or hypothyroidism, and pheochromocytomas. So the basic investigations were like these: full blood count, fasting blood sugar, serum uric acid, 12-lead ECG, serum creatinine with EGFR, and USCR. If a patient presented with hypertension and hypokalemia, what are the causes? It can be primary hyperaldosteronism. Then renin was low, aldosterone was high. Both renin and aldosterone high, then we need to consider either renovascular diseases, renin secreting tumors. And then familial hyperaldosteronism, aldosterone is high. Liddle syndrome, renin and aldosterone both were low. So these are the second hypertension clues, like if there are radiofemoral delays or any aortic stenosis features, lower blood pressure in the legs, and any other features of Cushing's, acromegaly, and then hypokalemic alkalosis patient, we need to exclude other secondary causes. So, assessment of hypertension-mediated organ damage, the sum was more than 35 millimeters. Or if the USCR was high, blood creatinine was high, ultrasound scan abdomen to evaluate the renal sizes, and carotid Doppler to exclude carotid plaques. So this is the most important thing. How do you treat hypertension in chronic kidney disease? So this is according to the SPRINT trial, which was the largest trial that showed this grade 2B recommendation. KDIGO recommends that the patients with hypertension and CKD, the target of blood pressure was systolic blood pressure less than 120 millimeter mercury when using the standardized office blood pressure measurement. So I will tell you what is standardized office BP measurement. This is a class 2B recommendation. This is how we recommend is at class 2, that is suggesting. So that's suggesting according to the SPRINT trial. So SPRINT trial is the largest trial. They recruited patients, 9,361 patients who had cardiovascular risk. Out of that, more than 2,500 patients, they included CKD patients, and they are non-diabetic and proteinuria. UPCR was they excluded with nephrotic range proteinuria patients, but more than 2,500 patients are CKD patients, which were non-diabetic. The primary outcomes of this trial was MI, acute coronary syndrome, stroke, congestive cardiac failure, and cardiovascular deaths. This SPRINT trial showed that there's a significant reduction in intensive blood pressure lowering group compared to the routine blood pressure management group. And also there is decline in eGFR more than 50%, and need for renal replacement therapy was compared, they were similar, but there is significant reduction in cardiovascular deaths. Cardiovascular outcomes are reduced significantly in intensive blood pressure lowering group. However, there are less certainty. Patients with diabetes, patients with polycystic kidney disease, nephrotic range proteinuria, very old patients, they didn't include, and also very late stage of CKD. So this is controversial in this group, but is the target blood pressure. Even diabetes, they didn't include. So then ACCORD trial, they excluded serum creatinine more than 132, but included patients with CKD, most albuminuric patients. This ACCORD trial showed overall reduction of cardiovascular events in type 2 patients with targeting 130 were low, and increased cardiovascular events with lowering less than 120. So that means ACCORD trial showed that type 2 DM patients, the target of systolic blood pressure less than 130. So the non-diabetic patients and subnephrotic range proteinuria or non-proteinuria patients with CKD, the target of blood pressure less than 120, monitoring with the standardized office BP. And the other trials that showed MDRD and ASK trials for the proteinuric CKD patient that showed that targeting MAP of 92, that is equivalent to blood pressure of 125/75 in standardized blood pressure, that showed the progression in proteinuric CKD. So they suggest targeting of blood pressure 125/75. So what is standardized office blood pressure measurement? Standardized office blood pressure measurement means that patients should be 30 minutes prior, avoid smoking, avoid coffee intake, and avoid heavy exercise. We have to ask patients, when you are coming for the BP measurement, you should stop smoking 30 minutes prior to that. And 30 minutes prior to that, avoid coffee intake and avoid avoid smoking. And then you should empty the bladder. When you come into the clinic, you should to empty the bladder. And for the more than 5 minutes, better if we can stay in a relaxed, calm and quiet room. And the technique can be used by validated, calibrated, manual or automatic BP measurement. So I mean, like there's no mandatory that we need to use an automated machine. We can use a manual machine, auto or manual, but accurately validated, calibrated, right? Arms should be supported. Cuff should be at right atrium level, and we need to use the correct cuff size. And there should not be clothing under the cuff. And then we palpate to estimate the systolic blood pressure, and then with the pulse. With the pulse, we are palpating it and inflate it 20 to 30 millimeters higher than that, and then gradually deflating it in 2 millimeter mercury per second. When you cut until you hear the correct cough sound. That is the accurate method of measuring the blood pressure. First, you have to palpate the pulse and inflate it until you palpate the pulse and inflate it 20 to 30 millimeter mercury higher than that, and gradually deflate the rate of 2 millimeter mercury per second until you hear the correct cough sound. It is ideal if you can measure both arms and get in the higher value. Okay. So this is how then, according to this standardized office BP measurement, the target of systolic blood pressure less than 120 is the recommendation. Right? That patient's feet should be also flat on the floor, back supported, arm in the right, cuff is in the right atrium with no clothing under the cuff, and arms would be supported. In quiet room, more than 30 minutes, avoid smoking, caffeine, exercise, and emptied bladder, and relaxing for 5 minutes. So lifestyle modification, I will tell later also. Once diagnosed, the lifestyle advice is less than salt intake, less than 2 grams per day, and physical activity average need to be done 150 minutes per week. So moderate intensity physical activity 150 minutes per week. So the first line of drug is ACE inhibitors or ARBs up to G4. It's either A2 to A3 albuminuric patients. The first line drug is ACE inhibitors or ARBs, and post-KT patients, it's dihydropyridine calcium channel blockers or ARBs. So what is ABPM and home BP monitoring? ABPM provides the average blood pressure reading over 24 hours. The device is typically programmed to record blood pressure 15 to 30 minutes interval, and the average blood pressure value is usually provided by daytime and nighttime. The nighttime average value should be less than 120 over 70, and daytime it should be 135 over 85 when we are using this ABPM BP recording. And if it's more than that, it will diagnose hypertension. And that can identify patients who have white coat hypertension, masked hypertension. Because we can't always measure the blood pressure standardized office BP. Then we can ask for this home BP. So how can we advise the patients for home BP? We need to ask 3 days, at least 3 days, 3 values per day need to be done. And we are getting the average of all those values. And if it's more than 135 over 85, it's confirmed as hypertension. So that is the home BP average, 135 over 85. ABPM also same average, more than 135 over 85. We should ask patients when they are monitor the blood pressure at home, they should do at least 3 readings for 3 days. So objectives to the KDIGO, that systolic blood pressure less than the objections were systolic blood pressure less than 120. They mainly rely on this sprint trial, and this standardized office BP measurement is 2 RNS, right? So there is no other trials they taken. So we go for other guidelines. So AHA guidelines, typical American way for everyone, they mentioned as target of less than 130 over 80 millimeter mercury. So, I mean, like the standardized office BP is usually 7 to 12 millimeter mercury systolic and 3 to 6 millimeter mercury diastolic, lower than the casual BP, because we usually measure the casual office BP, not the standardized office BP. So, standardized office BP is slightly lower, 7 to 12 millimeter mercury systolic and diastolic 3 to 6 millimeters, lower than the casual BP measurement. So the BP targets usually, according to AHA, everyone 130 over 80. For CKD patients, yes, European Society of Hypertension, they targeted systolic less than 140 until to 130, until the patients tolerate. And the diastolic for everyone, 70 to 79 millimeter mercury. So how do you classify what is grade 1, grade 2, and grade 3 hypertension? If it's more than 140/90, it is called grade 1 hypertension, grade 2 160/100, and grade 3 180/110. So grade 1 hypertension patient, we usually consider drugs treatment if the patient is having high risk for cardiovascular disease, renal disease patients also, we straight away start the drugs. But grade 2 and grade 3, definitely we have to initiate the drugs. And for other patients, always, first we have to ask for lifestyle modification like less than 2 grams per day salt intake, moderate physical activity. So this is according to AHA guidelines, as I mentioned. For patients with CKD, no diabetes or diabetic, or for everyone, they mentioned as, and post-transplant, it's 130/80. And for the KDIGO, they use the sprint trial with the standardized office BP. For that, they mentioned for everyone, systolic blood pressure less than 120/80, but the renal transplant patients, 130/80. So ESH, European Society of Hypertension guidelines, they target of 130 if correlated to 120, and for the diastolic, it's 70 to 79 millimeter mercury. So we have to make in my mind, we have to keep the mind that standardized office BP is 7 to 12 millimeter mercury lower than the casual office BP measurement. Then, how do you treat? So lifestyle interventions, less than 2 grams per day salt intake, moderate physical activity, as well as at least 150 minutes per week moderate physical activity, weight reduction, reduction of alcohol consumption, healthy diet, which is rich of fruits, vegetables, antioxidants, as well as not for avoid potassium containing salts because they are CKD. Any exercise is better than nothing. So how do you treat hypertension? So KDIGO recommends AZ inhibitors or ARBs for people with high BP and albuminuric, A3, A2, as well as A2 to A3. I mean, like either nephrotic or subnephrotic range proteinuria. Any patients with CKD, the AC inhibitors or ARBs is the number one drug until G4, G1 to G4. G4 means GFR until 15 ml per minute. That is class 1B recommendation. And G1 to G4 with A2 also class 2C recommendation. Both RAS inhibition for patients with mild to moderate to increase albuminuria. I mean, they didn't recommend for non-albuminuric patients with CKD, but this another trial showed that even non-albuminuric patients also up to G4, the ACE inhibitors is the number one drug. So this is how we classify the CKD. This is G1, G2, G3, G4. So up to 15 eGFR, they recommend ACE inhibitors. So ARBs is the first line drug. Sometimes you are worried, once you start in the ACE inhibitors, there is rise in creatinine, there is drop in eGFR. However, until up to more than 30%, we can accept that eGFR value, but drop. But if it's more than 30% eGFR on drop only, we will consider stopping this ACE inhibitors. So we should not stop the ACE inhibitors when there is pseudo hypercreatinemia, right? So A1, these patients, when do you consider referring to a nephrologist? Any patients with proteinuria need to refer to a nephrologist, or otherwise the patients with these red areas and these areas, they need to refer to a nephrologist. So, choice of antihypertensives in CKD patients, even in non-diabetic and diabetic, both ACE inhibitors or ARBs, not both together, ACE inhibitors or ARBs is the first line drug. And according to Hope trial showed that even non-albuminuric patients also recommends ACE inhibitors or ARBs. That is A1. A2 and A3, KDIGO anyway recommends ACE inhibitors or ARBs, but with other trials, A1 team also, they recommend ACE inhibitors ARBs as the first line drug. Then this is the order A, C, D, C. So ACE inhibitors, then if not controlled, calcium channel blocker, it's dihydropyridine, and then diuretics, and then there's a drug called clothaldione. Recent click study showed that indapamide and clothalidine are more effective than SCD for lower EGFR level patients. So it's a very good drug, indipamide and clothalidine, for the patients with EGFR less than 30 ml per minute. Even though when there's a rise in creatinine after starting the RAS inhibitors diuretics, we should not stop the drug. Only if there is more than 30% EGFR reduction only, we have to consider stopping it. So beta blockers considered as a second line or third line drug, it is come to a top rather than a disorder when the patients are class stroke MIs, patients with heart failure with reduced ejection fraction, pregnancy patients, post-MI patients will consider beta blockers. So this is the recent click study. It showed that for the patients with indipamide, there's beneficial in advanced chronic kidney disease. So if there is a monotherapy is inadequate, we have to combine the drug with either dihydropyridine calcium channel blocker or diuretics. So post-KT patients, post-transplant patients, the target of blood pressure is less than 130/80 with dihydropyridine calcium channel blockers or ARBs as the first. Usually within first 6 months of the post-transplant, we are not giving ACE inhibitors or ARBs. Then the dihydropyridine calcium channel blockers are the first line treatment. After that, ACE inhibitors or ARBs also as the first line treatment if the renal functions are stable. So according to 120 is the target value. And for the renal transplant recipient is 130/80. If the patient is not having adequate blood pressure control, it can be due to resistant hypertension, inadequacy of drugs, and inadherence. So these are the without CKD, type 2 DM patients, we usually recommend ACE inhibitors and thiazides as first-line drugs. For the other patients, ACE inhibitors and calcium channel blockers, dihydropyridine mainly. For the cardiovascular disease patients, ACE inhibitors plus beta blockers. So remember, patients with post-MI heart attack, post-MI patients, heart failure with reduced ejection fraction, consider ACE inhibitors and beta blockers. So, when you had the first visit, when the blood pressure was high, we have to titrate the therapy gradually. So, initial therapy is like this when adding diuretics or adding calcium channel blockers to the ACE inhibitor. So, step-by-step approach is like this. Usually it is recommended, unless there is no risk, low dose combination of 2 antihypertensives or even grade 1 hypertension. And if the blood pressure remains uncontrolled for 3 drugs combination, then it is classified as resistant hypertension. Then we need to exclude other secondary causes as well. And the other additional treatments we need to consider, like adding spironolactone or adding alpha blockers or clonidine. So we usually not recommend spironolactone if the EGFR is below 30. Below 45 we can use, but we need to closely monitor it. So this is the in kidney transplant recipients management. So patients blood pressure targets, as I mentioned earlier. Non-diabetic CKD with proteinuria patients, we usually anyway targeting of less than 120s, and for the post-KT transplant patients 130/80, and this is the resistant hypertension. When the patient comes with resistant hypertension, we will consider adding of spironolactone, and further if the blood pressure is high, we will consider adding prazosin or clonidine. So white coat hypertension, then we need to ask for home BP monitoring or ambulatory 24-hour ambulatory blood pressure monitoring. So for the patients who are in dialysis patients, so usually the ideal thing, because during dialysis their blood pressure varies. So we usually ask patients to do home BP measurement or ask the patient to come on non-dialysis days. And then we need to consider non-pharmacological treatment like adjusting the dry weight, increase dialysis frequency, and reduce dialysate sodium levels, and advice for fluid and salt restriction in dialysis patients rather than jumping into the drugs. And then we will consider losartan, like AC inhibitors or ARBs as the first line drug, and then add in dihydropyridine calcium channel blockers, as well as carvedilol is a very good drug for dialysing patients because the carvedilol has low dialysability effect. So because of the low dialysability effect, carvedilol also we can use for as an antihypertensive in dialysis patients. So, and pregnancy patients, when do you consider? If the pregnant patient's blood pressure is more than 140/90, you will consider initiating drugs. And beta blockers are first line drug, methyl dopa and calcium channel blockers. Severe hypertension patients, we need to consider. That means systolic blood pressure more than 160 and diastolic blood pressure more than 110. We need to consider hospital admission and start in drug with oral methyl dopa, IV labetalol, and if there is a patient is having eclampsia or pre-eclamptic patients needs urgent delivery, right? Urgent delivery and rapid control of blood pressure. Other patients, these are the first line drugs, methyl dopa, labetalol, and calcium channel blockers. And for the heart failure patients, ACE inhibitors or ARBs, beta blockers, MRAs, and then dihydropyridine calcium channel blockers. We should not use diltiazem like non-dihydropyridine calcium channel blockers or alpha blockers in heart failure patients. So as I mentioned earlier, MRA treatment usually carefully monitored when eGFR is less than 45, and once less than 30, we will avoid mineralocorticoid receptor antagonists like spironolactone. We do not have Fineron in the market at the moment. So as there were lots of questions about the CKD management, I just will go through about how when do you refer the patient to a nephrologist, as well as when do you screen the patients. And then this is the holistic approach for the patients with diabetes and CKD. This RAS inhibition should be there as a maximum tolerated dose if there is no eGFR decline more than 30%. And then if the still hypertension is there, we'll consider adding dihydropyridine calcium channel blockers and then diuretics. And still if the hypertension is there, we'll consider adding steroidal MRAs. And for the glycemic control, these two are the number one drugs, HDL2 inhibitors and metformin. And initiate if GFR is more than 20 HDL2 inhibitors. I'll talk later about type 2 DM and CKD. So these are when we consider patients how to manage CKD at primary care level. We should avoid dual blockages, inhibitors and ARBs, and contrast. Before giving contrast, we usually always should monitor the renal functions and adequate hydration and use the low volume contrast patients with AKI or risk for AKI. And we should avoid NSAIDs because I'm seeing lots of patients who are on NSAIDs without monitoring renal functions. And we should closely monitoring using metformin below 30. We should stop the drug. 30 to 45, 50% dosage. And eGFR less than 30, always stop giving metformin, bisphosphonates, and NSAIDs. And this is the first line drug, ACE inhibitors or ARBs, and then salt restriction, and then adding diuretics. And this is the target HbA1c 6.5 to 8. That depends on the age and the other comorbidities. And the number one drugs are SGL2 inhibitors and metformin, and then we will consider controlling with GLP-1 receptor agonist, but it's not available in the market yet. And therefore, the anemia, the target HB was less than 30 for the men's and less than 12 for the women's. And acidosis we need to correct. And we need to correct the vitamin D deficiency, especially for patients with CKD stage 3 to 5. And we should not nephrocentric. We should consider about cardiovascular disease risk because they are very high risk for cardiovascular diseases. For patients at any age more than 50 years, we always use statins, right? We always use statins, and age 18 to 49, if the patient is having coronary artery disease, diabetes, prior stroke, and high risk only, we consider statins. And aspirin also for the secondary prevention. And when do you consider referring to a nephrologist? If the patient is having AKI, for everyone, you need to consider referring to a nephrologist, or the patient's GFR less than 30, or rapidly rising creatinines, or UFR short active sediments, or resistant hypertension patients, you need to consider to a nephrologist and nephrolithiasis and hereditary patients. So that's my talk. So I think we can move to the questions.
Madam, there are some questions that has been sent before the lecture. One of the questions is, what are the admission criterias? What are the admission blood pressure readings for the patients to be managed as inward patient?
Yeah, for the patients, if they are having hypertensive encephalopathy features, they definitely need to be admit, right? More than 160 to 100 with hypertensive encephalopathy features. Otherwise, other patients we can manage as a outpatient, because I mean, like hypertensive endocrine features were there. That's what I mentioned in the previous slides, that if the patient seems to be having endocrine features, then we need to admit and exclude other causes and then treat the antihypertensive. So hypertensive encephalopathy is one thing, and then hypertensive endocrine failure, endocrine damage features were there. We should admit that, investigate that, manage.
Madam, thank you, madam. There's another question. What is the target BP in CKD and what's the target BP in end-stage renal failure?
I think that's what I mentioned. Target BP in CKD patients, according to SPRINT trial, when we are measuring the standardized office BP, the systolic blood pressure target less than 120 and diastolic to 70 to 79 millimeter mercury, less than 80s. And for the dialysis patient, we usually go for higher range. It's 140 over 90 dialysis patients.
Okay,
and
madam.
if you are not going according to intradialytic blood pressure monitoring, we have to do interdialytic days. I mean, like after the blood dialysis or at home, when they are not doing the dialysis, we have to do monitor.
Madam, there's another question. How can we follow a patient with CKD in a divisional hospital level?
Yeah, that's what I think. Can I share my screen?
Yes, madam.
That's what I mentioned in the last slide, this one. So patients, when at the peripheral clinics, we usually see in early stage CKDs, right? So if the patients are having high risk for chronic kidney disease progression, once we establish, diagnose, confirmed CKD, they need frequent monitoring, right? Every 3 to 6 months, please do UACR and creatinine. If there's a rise in creatinine, please refer to a nephrologist. And if there is AKI patient, definitely you need to refer to a nephrologist. And if the UFR showed active sediments and the hypertension not controlled, like with at least with 3 to 4 drugs, if not controlled, we need to refer to a tertiary care center, especially for the renal care. And patients who are at risk for CKD, like diabetes, hypertension, people who are living in CKDU areas, and family history of CKD, and past history of cardiovascular disease, and patients who are at high risk behaviors like HIV, SLE, and smoking, and obese patients, they are at risk of CKD. So they need, even though their renal functions normal, they need frequent monitoring with serum creatinine and UACR, and once established diagnosis, need to refer. Like at the primary care level, you can treat early patients, early CKD, diabetes CKD, and diabetes CKD patients, you can treat at the primary care level. Once EGFR less than 30, or the diabetic patients, if there is rapid rise in creatinine or nephrotic range proteinuria, we need to consider renal biopsy, then please refer to a nephrologist. Or otherwise, early stage diabetic and CKD, you can treat with metformin, SGLT2 inhibitors, RAS inhibitors, and maximum tolerated dose of statins for patients with age more than 50s, right? Or less than 50s with high risk for cardiovascular disease, we'll consider statin. So other patients, because in our area, in my practicing area, they are high risk for CKDU. So they need regular risk factor, risk screening with UACR and creatinine, right? Please do not stop screening, even though their values are normal. You have to consider repeating the screening program. And there is rise, you can refer. Okay.
Right. Okay, ma'am. Thank you very much. So today we wrap up the session. Our sincere thanks to Dr. Nadeesha Nishanthi, consultant nephrologist, teaching hospital Anuradhapura, for her excellent lecture and the time she spent on educating us. Thank you very much, madam, again for conducting today's lecture. So
Thank
to
you,
everyone, the correct e-certificate link has been put to the chat box, so you can click that and fill in your details to get the e-certificate. And thank you very much for joining on with us with this lecture on a Sunday morning to improve your knowledge. And we hope that you will join with us in the next lecture also, in the next Sunday in the Sri CPD weekly webinar program. Thank you very much.